The main reason that we think that the patient might have had development of this adnexal carcinoma, really the only risk factor that we've found is his history of UV exposure. But other than that, he really doesn't have very many other risk factors, including no family history, no history of the immunosuppression or radiation, which are all risk factors for adnexal carcinoma. And in regards to how the immunosuppression and lack of previous radiation exposure played into treatment, so with adnexal carcinoma, it's more a local regional disease. It very rarely metastasizes, and because of that, the general treatment for it is wide local excision. And so that's what we did in this patient. We just took a wide excision of the tumor itself. Thankfully, he didn't have metastatic disease, so we didn't have to pursue further treatment other than the excision itself. For him, thankfully, because he doesn't have metastatic disease, we didn't have to use PD-1 inhibitors. Because of the rarity of the tumor, there's no standardized treatment for metastatic disease at this point. There's not enough of a sample size to really to find a standardized therapy. And so because of that, when it comes to treating metastatic adnexal carcinoma, people use like case reports or just one-off treatments that have worked in the past that people have written about. And so when I was looking through the literature, I saw a few instances, like 3 or 4 instances where they've noted disease regression and success with using pembrolizumab specifically. And so given that immunotherapy seems to be the way that oncological treatments are heading, it definitely would warrant further investigation to see whether or not we can standardize any type of therapy for this adnexal carcinoma. Just recurrent skin checks, just to make sure if in that region, the tumor itself doesn't come back, and it has you can kind of see like a pretty, specific appearance. So I think it's important for him, because of the high risk of recurrence, to definitely get close follow-up, because he is 17. He has a lot more years ahead of him versus the average person who usually gets this type of tumor. The average age of diagnosis is around 65, and so because of that, that patient, might not need so many follow-ups versus someone who's 17 has a lot more life ahead of them, I guess is one way to say it, and would require more consistent follow-up. And then because of the low risk of metastatic disease, I guess in someone who's older, the follow-up doesn't have to be so like strict and on a timeline, but with someone who's 17, that the risk of this to metastasize is larger just because they have longer life ahead of them. And so I think that's why it's more important for someone younger to get that close follow-up. This is a rare tumor, and diagnosing it is also difficult because it's not really seen very often within the pathological world either. And so I think those are just things to keep in mind when you see lesions that look abnormal.